Terrific. Okay, thank you. Um, Telehealth Failures and Secrets to Success video podcast. And I'm really excited having Professor Homero Rivas on our show. I think most of you guys probably know him. He's extremely famous professor at Stanford, written books, just like given so many talks in there. So I think it seems like everywhere, done a lot of interesting projects in there. I guess as we start, Homero, I know like people can read your official bio. Is there something that like just something you don't about yourself that you normally people cannot read from your official bio that's very interesting about yourself?
No, I mean, I think when it comes, I have a very different profile when it comes to medicine because I take care of people who either eat too much or people
Mm,
who cannot eat. But that's very
mm,
different. That what brings me here. I'm a strong advocate of mobile health and telemedicine, and
mm.
that's based on the fact that we just
Yeah.
have like this tremendously long clinics that they're very repetitive, and that
Mm,
made me just see something that there's great promise
mm.
in information and communication technologies where you implement them in healthcare. No,
Yeah.
um, other than that, just a regular guy.
Sounds good. And by the way, for the people who tune in, I apologize. My videos are poor. I'm in Qatar this week, and unfortunately, the hotel network is not as good as it could be. I really apologize for this. But next week, I'll be back at home and be a normal setup. I guess, Omer, maybe you can start with just maybe share with us a couple of slides, your thoughts in there. Then after that, we just open up. And on the person level, I've been looking forward to your presentation because I've been doing the like a digital health for about 10 years now. It's always a frustration of things are so
Yeah.
slow in healthcare. I think everyone in the audience, I think they'll experience that same thing. So I think we're all eagerly to see your
Yes.
insight. How do you make things go
So
faster?
if Anne, let me see, because Anne has my talk, but let
Okay.
me just, but the one thing I can tell you is this: I see it. Very good. hmm Give me one sec. But in medicine, and we practice this thing quite a few times. Okay, and there you go. Okay. Um, in medicine, things go at a very different pace than actually in technology and in science, and that could be for many reasons. But if you think about it, there's been physicians like for thousands of years, and in many different ways. And I think for the rest of humanity, there's still going to be physicians. We will practice in many different ways, but that will be a fact. But one of the things that we see here in the U.S., we spend almost 20% of the GDP is spent in healthcare, and still we have lots of inefficiencies. And you would wonder why is that? Uh, and I was telling you about how we have had medicine for a long, long time. But the business model that we have had hasn't really changed for that matter. Why? Because our practice is really not scalable. Um, if you think about like right now, it's a great thing that we can reach out, people like pretty much anywhere throughout the world with this system. You yourself, you're in Qatar. I'm in California, but people could be in South America or other places. Uh, and it's something that is highly scalable. Software is highly scalable. Medicine itself, it's not scalable. I have to, after so many years of training and so many years of studies and practice, I was this week, yesterday in the operating room. I took care of only 4 people, and I arrived home at 9 p.m. after working all day in the operating room. It's just not scalable. It's just you cannot just bring it to masses. And that's one of the things that can be very frustrating. So yes, with digital health, like implementing information and communication technologies, we certainly can do this. But let's talk a little bit why I think that it can be very challenging for physicians to innovate, and why it takes so long. And that's just because of, it's not really the DNA, but it's just the way that we are brought up, for that matter. You know, if you think about like successful innovators, for the most part, I'm not saying everyone, because there's a lot of controversy if people really have high tolerance of failure or not, if they really take lots of risks or not. But most people, most entrepreneurs take more risks than the risks that physicians will take. Physicians were very risk averse. We go very cautiously about it. And so, you know, successful innovators, on the other hand, they're people who are just very opportunistic. They're very social. They persist. They fail a few times, and then they keep working on the same thing. But on the other hand, as physicians, from day one, we are told that we have to, be very focus oriented to never fail. So we always are trying to follow this predictable risk that usually is going to be very small and very low. So by nature, if you don't risk, if you don't look for new things, for different things, if you always follow dogmas saying like you have to do it this way and that's it, you never question, well then the innovation will go at a very low pace. And yes, we in medicine and at places like Stanford, we certainly can innovate many things. But for the most part, one thing is to, be creative, execute, innovate, but then to implement that innovation here in the US, it can be quite challenging, especially at places where there's a lot of liability involved. And that's at a place like this. So good or bad, we first go and try devices in some other places, like, as I mentioned, it could be in South America, it could be in Africa, it could be in Asia, it could be Europe, whatever that may be. But probably we're the last ones to implement that innovation. And it can be sad because it's somewhat hypocritical, but it's the reality. And the other thing, all these things, all the culture that follows a surgeon or a physician like this, it will also create that mindset that we're going to be just very slow adopters for this. And a lot of that is based, once again, on the education that we receive. If you evaluate the medical school curriculum that most modern medical schools have, of course, you're going to see that you're going to have subjects that have basic sciences. You're going to see subjects that have things such as anatomy, physiology, pharmacology, all those things. And then as you start taking care of patients, how to talk to patients, how to treat patients, and all different specialties. But still very, very few medical schools or nursing schools or schools for healthcare extenders will actually include things such as mobile health or digital health or telemedicine. So therefore, once you have those physicians who are, board certified and they're starting to practice, that's that never really goes through their mind. And so you have a bit more of a difficult time trying to persuade them that those would be actually very good ways how they can transfer care with the use of different technologies. And interestingly, the first ones to actually, or the best advocates for digital health technologies would be the patients themselves, because they're the ones who worry about themselves being taken care of. So I would say the biggest hurdle, with no question, of many different technologies is really not technological, is not the battery, is not the cost, is not the weight of the system, is not the resolution, is not any of those things, but usually it's the mindset of those involved in care that would be the biggest challenge. some of the things that we have done here at Stanford, in my experience, is like, it's been probably 5 years already since through a seed grant that we had from the Vice Provost's Office of Online Education, we're able to develop a course on mobile health, which pretty much it was directed to the design and use of mobile phones to create strategies that would implement healthcare, for that matter. If it's only informational, if it's to aid with education, if it's actually to help with telemedicine or with public health strategies, so usually basic things. But actually, it was a great success for us because we were able to see that there was a lot of interest throughout the world to learn more about the use of this telemedicine platforms, and that evolved into a course that we actually started last year. I was mentioning as well that most of the medical schools do not have a curriculum how to teach about telemedicine, and we had a number of experts or pioneers in the field in many different ways that we have at Stanford, and we had this was offered to undergrads and also to medical students throughout the fall. Where they could actually learn more about those different technologies. At the same time, I'm very involved with other medical schools, and this is the Mohammed bin Rashid University in Dubai, where I will be practicing this summer. I will be moving out of Stanford into this medical school, and it's very exciting because they're truly innovators. And here we're trying to implement not only digital health technologies, but other innovative platforms such as design thinking and a number of different ones. Very early on, since year one for med school, so you can create that mindset in new practitioners. So when they go into the practice and taking care of patients, they actually do not have that challenging change of mindset, and it's already something that they believe and they can implement these things. Other ways that we can do, we have been able to do things. We have this so-called AID Lab, which is the Emergent Innovative Global Health Technology Lab. And that's just a collaboration with different schools and also with different expertise, for that matter. It's not just as physicians, but it's also a number of computer scientists, students, entrepreneurs, trying to work with things from, as I said, mobile health to the use of drones to deliver healthcare. To other things such as the use of telemedicine, etc. But it's just, I think that the question here is really not to just produce the same type of physicians that we've been producing for the last 100 years or more. It's not the number of physicians what we actually need, but it's just to find new mindsets, as I said, innovative mindsets that adapt to the 21st century, because the education that we have in many ways still does not adapt to that. And hopefully, that will be a reality that we can see in the next, 10 years or so. But anyway, that's just a very small brief presentation, so I can actually incite some of the conversation that we could have more than anything, because we could talk about things like this all day.
That's really great. Really appreciate that. I guess in some sense, like, do you find it's like all of the innovation from AID Lab, it there are these little bit of self-selecting. What I mean by this, like the physician who are really innovative, they're drawn to these. But the big challenge, the people who like, maybe the people, the status quo who would never, join one of the innovation. Like, do you feel like have some idea how do you get that group of people, getting them to do something different?
Yeah, it's you're correct. I mean, a lot of that is going to be what's the status quo. What the computer scientist or the engineer or the physician they have a passion for. Uh,
Mm,
but I would say, you certainly have to go first with low-hanging fruit, things
mm,
that make sense. But it's I think the key, with no question, is just to go beyond that and just go to the very mindset in trying to create things. It's interesting how, for example, for like social media and medicine, it's a fact that we go into clinic and every single patient has interacted with tons of patients through social media,
yeah.
and that's almost something like, it took us by it's natural, it's normal, but we never really
Mm,
truly talk about it in medicine, like,
mm,
should we pay attention to that? And I think it's something that we as physicians can learn so much from it, that unfortunately, up to this point, it's really not it's underutilized.
mm,
The use of, like, telemedicine, for that matter, everyone, there's so many patients who go into our office, and they would like to, some secretively and some not, but they say, hey, like, can we share this
mm,
conversation with my such and such over the phone? Well, over the phone
mm,
is not, the best thing. Sometimes, as I said, it's
mm,
secretive. Sometimes it's not. But there's so many
mm,
different technologies that we have nowadays that it should be something more formal.
mm,
Uh, I think some of the challenges that we have had is for example, physicians. I think that there's always the worry about liability, because we worry about
mm,
being sued and, like, oh my God, they're going to video record and this and that. And I think if anything, it improves the quality of care that you have for patients.
mm,
It is quality control, like if you can
mm.
video record some things or not.
Yeah.
And
I mean, I think,
yeah, I think it should be done.
yeah. I mean, my observation, in general, right? I mean, this might be going back to the days when I was an undergrad, like the people who are pre-med, right? These are very smart people, right? The people are usually the top of the class, right? They go to pre-med track, people, get insanely high grade, they become
Yeah.
doctor in there. So almost like if I were to observe this, I feel like the underlying brain power of the physicians are the top, the top echelon of society. So they are more than enough to be innovative. But something you struck at the beginning, a slight talk about, like, the medicine has a very poor business model. You almost feel like the incentive structure is you're not, you don't get rewarded by innovator. You're really as a fee for service largely. I do this thing
And
the
that's
same
where
thing.
I was going to, because many of this, most of the video conferencing that there is doesn't really get reimbursed as it should. There's
Yeah,
still some challenges, and so that's just another one extra. But you're right. I mean, innovation itself, it doesn't. I mean, people do it just either because they're passionate about, or because they have to.
yeah,
Uh, but incentives is something that should be uh, better design
yeah.
when it comes to, innovation, with no question.
Yeah, I almost feel like if you had a proper incentive alignment in there, then I think you could get physician to be the most innovative in the
Yeah.
long term, like compositions aligned.
No, but I think things are getting a lot better. It just takes
Mm,
time. And as I mentioned before, I think
okay.
this will be a generational change,
Hmm.
because young physicians, I mean, like my daughter, like, she's 5. She grabs the phone, and she just, even if they change the new software, she's gonna figure it out. And that's gonna have, when she's gonna be a teenager and when she's gonna be an adult, she will oppose to go and wait hours to see someone. She'll be like, I have to see them online. That's
Yeah.
a fact. So, and by then there's going to be all this artificial intelligence that you were saying, and you will get suggestions as a patient without even seeing a doctor yet, probably. So that will be a generational change that, with or without the incentives, is going to happen because it's a convenience factor.
It's convenient. Yeah, that makes sense in there. I guess I would say for the audience member, feel free to type your question in there. We'll take them on the air in there. Then I guess in terms of like the poor business model, just to continue, like, is there like an ideal or at least better business model for medicine if you were to just maybe not just within the U.S. context, just you like the global, do you see that it's another model that makes actually more sense?
Yeah, I mean, that's a really good question. But I think the best business model, I mean, this is very controversial, of course, in many ways, but the best thing would be to make people stay healthy.
Okay.
So, because usually we spend 80% of our resources, in 20% or 10% of people in the last year of their lives. And so when they're like, super old and super sick, and we try to keep them alive, that's where we spend lots of money. And I mean, it's okay. Of course, we all want our loved ones to last longer and better. But I think that we need to find ways how usually 1% of the healthcare budget is spent in prevention. We should be able to spend more money on prevention, and that gets incentivized. That we as physicians get paid more for maintaining our patients healthy, and probably maybe also patients. I mean, there's been some interesting examples. Like one of those is in the UAE. At some point, people were being paid gold to lose weight or to stay.
Yeah.
I'm saying, I'm not. You don't have to go to extremes, but if you make some ways how we can make people stay healthy, that would be the best way. Because that's how you invest your money more wisely.
That makes a lot of sense in there. In fact, like we've been under this American dog, we've been cooking on some sort of like a new way to think about insurance in there. So I think the way we model everything out, it's cheaper to actually pay people to be healthier because the model you actually work out a lot better. That's why I almost feel like maybe the way to just get insurance people, insurance actually pay you. Yeah.
And some people decided, well, maybe if you pay like premiums, that if you make them much bigger, then people will try to stay healthier. But I think it's a challenge. It's a challenge that our leaders in healthcare have to somehow figure it out. But I think we're in a much better place now that we have all these different technologies, and I think we have to be able to find ways how to implement them better. Yes, it's yes.
Yeah. Okay, Omer, do you have, from your years of looking at all the examples, both US as well globally, I mean, have you seen examples where the innovation adoption was really quick? And was there any insight from those case
Yeah.
studies that you felt like everyone should be used as a best practice?
No, I think, well, it's not easy because I mean we live here in the U.S. It's 300 million people. It's not as it's all these different states, all these different authorities. Everyone wants to say something, but clearly when you have a much smaller place where you have Singapore, for example, you have just a single authority that is going to say like this is going to be done this way. well, probably it's going to be much easier to
Mm.
innovate in many
That makes
ways.
sense.
And that is just by
Mm.
means of the nature of
Happen. Yeah.
the system and the stakeholders and all that. Um, that's what I think. It's
Got it.
but I think with no question is like if in your family values, if you
Mhm.
instill them since very early, that will be
Mm.
much easier. More good chances that those values are going to be instilled. Where I'm going, we have to educate our physicians when it comes to health, about like cost containment, about like the technologies, about all these things, so we can hopefully change that mindset to a
Mhm.
better one.
Okay,
Uh,
that makes sense. So we have a question from the audience, David. So he's
mhm.
asking, so like, how is the cost of getting various level of physician experts being addressed when you have them sort of by telemedicine? Like, does that change any of the
Okay,
like
so
cost?
the question again, the cost.
Yeah, how is the cost of getting various different level of physicians and experts and specialists being addressed? I guess when you have telemedicine versus like a no telemedicine, like
Yes,
does that change the cost? Yeah.
yes. Well, the cost itself. Um, I think what they're trying to say is like, there's gonna be the same way that you have some specialties,
Hmm.
that you're gonna have more specialists of a given thing than others. There's gonna be some people that are gonna be more in demand.
Okay.
And there's the good or bad. I'm not so sure. For example, I think there's a shortage of primary care physicians,
Okay.
and one of the reasons for that is because they not get paid enough. They should actually be paid more. So there's more people. That's an incentive for them to be,
Hmm.
more. Whereas probably, I don't know, someone who does some fancy thing, a transplant surgeon or a
Hmm.
cardiothoracic surgeon, they may get paid more. But I think the physicians themselves, we should value the need that we have for
Hmm.
them, so they can get paid,
Yeah.
they can get paid more. As far as with telemedicine, I think that it allows you to actually be more marketable, because you're in different, you're virtual, you can be pretty
Yeah.
much anywhere. And I think what we just need to do is find ways how your license can be
Hmm.
a national license, and not
Yeah.
just work in one given state.
Yeah. That makes sense. So we have a question from audience, Celestine. I guess this is a follow-up what we just talked about. So she was saying, so prevention is the key. So we don't really have like healthcare, right? We really have sick care. So I guess
Yes.
what would it take to get real healthcare to like how do you get healthcare system to keep people healthy? Do you have some thoughts on that?
Yes, well, there's some different models. For example, um, they are the model of concierge medicine, for that matter,
Mm.
where people pay like a given amount. Like, okay,
Yeah.
I'm going to pay. I'm exaggerating, but I don't know, 10,000,
Hmm.
20,000, whatever, and so I get access to my given doctor
Hmm.
anytime throughout the year.
Yeah.
Well, that doctor has a huge incentive
Yeah.
to maintain their
Yeah.
patients healthy,
Yeah.
so they don't bug him, so they don't bother
Yeah.
him. I mean,
Yeah.
that's clear. So if we find ways how we can, truly get doctors engaged, that they care, so
Mm.
so even high risk patients stay as healthy as possible, that would be great, you know. But
Yeah.
it's and sometimes those incentives have to be created outside the national health system. I mean, the Medicare and Medicaid, but
Yeah.
outside, like as I said, with entrepreneurial like systems like concierge.
Mm.
But the same employers, it's on their best interest if their patients are not going to the hospital all the
Yeah.
time. So organizations like Stanford, they actually
Yeah.
pay you to exercise and get your vital signs checked. No, stuff like that. Maybe it's a waste of money. I don't know. Uh, but it's just trying to find different ways
Yeah.
how to keep people healthy.
Yeah.
Um, yeah,
If I was thinking, it's like the basic premise, despite all this, capitated, it's like at the majority of healthcare system is still fee for service. As long as you have that
yes,
fee for service as a dominant economic engine, right? Then the incentive structure is really is not rewarding for,
yeah.
you
No,
know.
it's that
So
indirect thing. I think maybe if you, I don't know, if you keep someone without getting sick
you
for
get a
so many
bonus.
days,
Yeah.
exactly, something like that.
Yeah, I
Uh,
think so as you have that, I think that like you're gonna see all this magic innovation will happen.
yes.
Yeah. I guess we have a question from audience Jane. So she's asking like, so how do you view digital health in terms of supporting things like urgent care situation, or is like digital health so better for things like more routine, like follow-up cares and so on?
No, I think you can tap into whichever field you can imagine. For example, with urgent care, I can only imagine there's overcrowding of ERs and
Yeah.
urgent cares. And most of them, it's because of people that they actually don't need to even be there.
Hmm.
So I think at some point, the first thing you will have like artificial intelligent engines that will go through a screening, and it will say like, listen, maybe you shouldn't even worry about it, or you should just call this number. And that would be one way to like get rid of a few. And then maybe other things, you can document way in advance through pictures, video, uh, teleconferencing, something, and you can just so they already tell you like, just be reassured. You need to come here, but you don't need to like. It's not
Yeah.
like a super emergency, stuff like that. So there's I think there's great benefit.
Yeah, that makes sense. I guess, it's really interesting is maybe I just keep on going back to the business incentives, like over the
Yes.
past, I would say about 12 months, I had a bunch of conversation. So like at VSee, we've been focused a lot on this with ER diversion to thing. But often that like when you have this conversation with ER, when you go like, behind, just like, they say, well, at the end of the day is right, it's like having physicians show up, I mean, for patient, it's actually increase the revenue. So when you do the true ER diversion, it has a huge impact. There's suffering. So in that case, it's one of these things where like they want to do the right thing for everyone, but it just at the end they have to pay the bills too. It's like,
But that's one of those things because we are in medicine because of our passion to help people, to help
mhm,
people. It shouldn't be because I am going to make so much more
mhm,
money if I, do it or not. I think, yes, one of the things that you want is to find as many ways as possible not to have as many
yeah,
people in your hospital. Of
yeah,
course, to finance people, they're going to say, well, we're losing patients, this and that. But
mhm,
you should be able, as I said, to also have incentives by avoiding people, to
mhm,
to come to your emergency rooms.
yeah, makes sense. So we have a question from audience John. So he's asking, so the VA seems to be the leader in telemedicine, right? They've been like, so again, why isn't more emphasis for people just putting the best practice that we are using and people just adopt those in the sort
Yes.
of commercial markets.
Well, and I think it's true what John says. I think it's been 20 years. I remember being in training and seeing the telemedicine being used at the VA, and that's because of the needs, because they haven't had, sometimes you don't have providers, and then you have these patients who don't have great access. They're veterans, they have problems with their legs, whatever that may be, and so it's a phenomenal way how to do that. Now, the VA, it's a federal institution, so and it's like the government itself. It's impossible to translate that business model to a for-profit business model that you may have at a center, in the city. But I think it's a great example to see how, for many things, it can work well. And of course, they have many deficiencies as well. And there's things that they may not do as well as probably they could. Uh, but no, it's I think they've been very successful with that.
Yeah, that makes sense. So we have a question from the audience, Akma. So she's asking, so aside we talk about sort of reimbursement for telemedicine as one of the sort of maybe barrier with the business model. Like, so other than that, like, what are some other changes do you see that's where like a blocking from telemedicine, like just taking out, getting widely adopted?
Yeah, no, I think one of the things is, well, we said the payment, the reimbursement. But the one that I mentioned in my brief talk is the mindset that we have. I think among physicians, there's a mindset of liability, that I am liable in the sense that someone can video record my conversation, and then that can be used against me if something happens, because they have evidence. And so there's a lot of that, believe it or not, that physicians worry about it. I think on the other hand, if you explicitly, in a professional way, explain everything that you have to explain to the patient, and they have it well documented, even if it's recorded, I think you have a much better chance of being well protected. But I think that's one of the other things. I think nowadays any computer, I mean anyone who has a smartphone for that matter, can engage into a telemedicine consultation, and that would be great. As a doctor, you may not like it as much, but as a patient, if you are in Qatar and then you get sick and then you want to talk to your doctor, you'll be very happy.
Yeah, it'd be very nice.
Yeah.
I guess we'll have another question from the audience. Fumi, so I guess she's asking about so in terms of like a telemedicine, so you cannot do physical examination. So like when you don't have physical examination in the telemedicine, how much does that influence like it's a sort of the physician's confidence in making an accurate diagnosis?
That's a very good question. And I would say it depends on the specialty, okay? But there's specialties that close to 100%. I mean, there's like radiologist. I may be exaggerating, but most radiologists don't need to examine their patients. Most of the things that I consult with patients, and I don't want you to like get a wrong impression, but I don't have to rely on the physical exam, because if I talk about a difficulty with eating, or someone who, on the other hand, eats excessively, and we talk about different things, there's really no need for that. And with no question, the physical exam is something that it's quintessential, it's something that is super important. But we have more and more different technologies that we can rely, even in a much better way than the physical exam itself. We have ways how you can get an ultrasound and then transmit that like directly. We have ways how we can get the EKG monitoring. We have ways how you can listen to sounds. We have much more sophisticated ways of taking pictures of skin lesions that can be at some point, like, evaluated in models of artificial intelligence, looking at the ear, looking at the eye, looking at the mouth, so many things. Yes, ideally you will want to have someone, but I'm not saying it's not a panacea. It's something that it's just another way of leveraging in what you have and in what you know to make medicine and the practice of medicine better. That's it.
Okay, do you have a person prediction? How far are we from like the Star Trek tricorder? Just gonna do a scan, from fancy.
Oh,
In this
yeah.
case, you really truly don't need to touch. So,
It's funny, I like to. I don't have much free time, but I always like to watch like sci-fi movies. And last night I was watching Alien and Aliens, like first two, and that was in '79 and '86. And it's crazy how they have all these things, and still we don't really travel to space as extensively as in those movies. But excuse me, but it's going to happen. It's going to happen.
Do you feel like it's within the next 5 years, 10 years?
No, I think it's going to. No, I think it. But I would say, within 10 years or so, the way we practice medicine is going to be so different. And this telemedicine thing is going to be very common. I am very optimistic about it. I still be doing surgery and I'll be still complaining, and we'll have lots of challenges. But I want to say that with no question, in 20 years, it's going to be just very, very, very different. It's already very different than it was 20 years ago.
Yeah, that's exciting. Yeah, I guess we have another question from the audience. Fume, she's asking what about in terms of point of care tests? We know in the Silicon Valley we had the notoriously the bad example. We should not mention that.
Yes.
Do you feel like to how much is that going to impact in terms of the adoption of telemedicine?
No, I mean, I don't think it's going to be a deterrent for it. I think there's going to be, there's good and bad examples of successes and failures. But if we just keep punishing ourselves with things that have failed, we will never, innovate. I actually admire the leadership in that company, how they persuade. I still can't believe it. It baffles me. But at some point you'll be able to get those diagnoses with your phone, and a number of different things, and I think that's great. And it won't be a diagnosis, it will be just a way how we can get more information. I mean, I was just thinking of just this moment about you get your genetic code now, whereas before that's like science fiction, and now you can learn so much about yourself. It's crazy.
It's pretty cool.
Yeah, it's pretty.
And then, as we wrap here down to the end of the hour, again, I apologize. There were a couple of questions we didn't get to. Apologize, we did not. So we're going to send to Homero some of the questions. We're going to post the answers when we publish the recording. I guess, Homero, as we wrap up the session, if I could do maybe like a rapid fire, just ask you 3 quick questions and just like a single answer. Okay, the first way is, you share a lot of these insight and wisdom in there. So if you want the audience to just learn one thing from you today, what do you want the audience to learn from you?
Stay positive and be open to new things in healthcare. It will be safe.
Excellent. The next question is, so what is something that you believe in that the rest of the world do not believe in yet within the sphere of digital health or innovation?
Well, I think just we're repetitive, the thing that we're just going to be observers, doctors, and artificial intelligence is going to help us do so much. And we'll just check, yes, that looks great.
Got it. And the final question is, so if you can whisper one idea into President Trump's, I guess he'll just do this thing. What is that one thing you want him to do in regard to healthcare?
Well, I would say it's something impossible. Like no, I don't want to say much. I mean, but I would say the primary care physicians, they need to be better paid. Probably they need to be top echelon, and telemedicine needs to be reimbursed and pretty much mandatory in all practices.
Got it. Okay. Okay, that's wonderful. He should do that. So
Yeah,
we'll pass on the word through our
okay,
social
very
media
good.
channel. Omer, thank you so much for spending an hour with us sharing insight. I personally really enjoy it's
Me
something
too.
definitely think about innovation, like just getting people change. Definitely something we struggle every single day, but really appreciate insight.
Excellent. Great talking to you, and hello to everyone.
Thank you so much. And can you bring up the closing announcement slide?
There we go.
Okay, great. Okay, so again, thank you so much for everyone for tuning in this week. So again, so we're pretty excited. We're gearing up for the American Telemedicine Association. So again, we have we actually have the biggest booth this year. We have a lot of exciting talks, from Amazon to Optum to UCSF, a bunch of really interesting talk is actually happening inside our booth in there. We also have a bunch of interesting companies that are co-exhibiting with us. We have this joint marketing program. It's going to be pretty exciting. It's a way to, because for our ecosystem, like everybody helping each other, we're going to share sales leads in there. Definitely contact Becky if you're interested. Again, we're still gearing for our competition in Southeast Asia for this bold motorcycle backpack design competition for digital health. Definitely send Jem an email if you're interested to maybe be whether a sponsor or a judge. Again, we're making a lot of progress on writing up our blueprint for how to actually decrease costs of healthcare. And again, we'll send this fairly widely if you're interested in being part of this. Definitely, give Sophia a call in there. And then our annual conference is October 2nd to the 4th in there. We have some really exciting speakers in there. We're not quite ready to announce, but really big names, really interesting, thought-provoking in there. You can do about just like what Omer's the theme this hour, just rethinking healthcare almost from the ground up, rebuild it, think about business model, so on. And the next Thursday, we have a episode focused on, again, so drug prescription, various things. And again, then we have a pretty interesting insight from Dr. Davidson. Hopefully, definitely tune in for that. Again, thank you so much for everyone for tuning in. Again, thank you so much for Omeros for sharing your insight with us.
Thank you.
Bye.
Thank you, Milton. Thank you, everyone.
Thanks.
Bye-bye.